Okay, I just received the message that we can start. So I'm very glad to be here with you in this aligners course. And I also would like to thank OHIS for the invitation. It's not the first time I'm here with you, but this time it will be special because we have 12 module course to discuss very deeply a lot of concepts and to share my experience that I'm having with aligners for the past years. Okay, so this course will be in English, but we have an amazing team from OIJS to do the translation for those who don't speak in English. Okay, and the whole idea here is for you to make questions, and we are reserving some time in the end for us to answer and to discuss. So let me introduce myself. My name is Daniel Ramos. This is the pronunciation as we talk in Brazil, where I'm from. I am orthodontist for about 20 years, more than 20 years. And I have been working with aligners, Invisalign and other companies for about more than 12 years. In this journey, I lecture in several universities, and right now I am living here in Spain, where I coordinate the orthodontic department for the digital smile design in the planning center, where I am now. Actually, as you can see behind, you may see some people, some colleagues working and walking, so please don't mind about this. Okay, we have a big team here, a lot of dentists and designers exactly doing this kind of digital treatment planning, digital diagnosing for clinics all over the world. We have right now 100 clinics working with us and plus other dentists individually. So we use the collective intelligence to create treatment plannings, digital treatment plannings. And when orthodontics involved, I am the one with my team of orthodontists who get on board to make the call. Okay. I am a speaker for DSD. I am a speaker for Invisalign, but I don't receive anything for them. I'm talking from my experience, and the concepts I'm going to use in this course, they can be used for any system. Okay, I want to make this statement here in the beginning that although I'm going to use the software from Invisalign as a reference, what I'm going to share with you, you can use in any system. Okay, and I'm also a member for several associations: Brazilian Association of Aligners, the Aesthetic Association in Brazil, and international. Okay, this is actually where I started doing more interdisciplinary treatments, because I understand orthodontics is part of this engine, right, where we have a lot of other specialties working together with the same goal, providing a beautiful, functional smile to the patient in the end. And at Well Clinic is the birthplace of the concept of digital smile design, right? It's the clinic of Christian Coachman in Brazil. His father owns the clinic, and I was his orthodontist for a while, right? Before coming here to Spain to be to working with DSD. Nowadays, I keep doing my job as orthodontist, but like a virtual orthodontist. This is the times are changing, right? So I can do virtual plannings from here and provide care to my patients in Brazil. And also I am working in the planning center, as I mentioned before. So in this environment, I start working with amazing dentists from several specialties where we discuss together the cases. And the way I was planning the cases, the way I was diagnosing my cases changed. And I would like to share, mostly in this first webinar, how we are doing this, right? How we are showing to the patients in a better way what in the past we just had here in our minds and use only words to show them what is the need for his treatment or her treatment, okay? And this is something that we can do in a team effort, Okay, because I worked there at Clinic, this interdisciplinary clinic in Brazil, this most famous clinic in Brazil, and we work in partnership with DST. I received this award, most cases treated in the year of 2020, before the pandemics or during the pandemics, using DST Invisalign. Okay, so this is something I'm very proud, and this is something that provides me a lot of support and basis for me to create my protocols with my experience. Okay, so digital orthodontics, as I mentioned, the biggest advantage nowadays is the possibility for collective intelligence, right? So we can use the digital to share images, to share ideas with our colleagues, to get opinions from doctors all over the world. In the past, we just had our clinic and the doctors who were working with us. Sometimes the orthodontist was alone. But nowadays, with the digital, you can easily share the presentation, share the project, share any software image with your peers to discuss, to get to the ideal treatment, the best treatment plan possible. Another benefit, it's also that we can personalize strategies and start by the end. We can start by the final ideal, okay? We can start by the final ideal design, the ideal position for teeth, and also we can use this as a reference and do a reverse engineering process to understand everything that is going to be needed in order to achieve this outcome, okay? So the digital allows us to do this, and this is a big difference. I like to mention this a lot with my patients. We can reduce mistakes, okay? Because in the computer, we can test drive and do a lot of options and then understand what is the best one and which one is the best, and we can double check our decisions, and it's much better in the end, okay? And because of the digital also, it's easier for us orthodontists or those who are working with orthodontics, because this course is not just for orthodontists, it's for anyone who is using aligners. It's easier for us to integrate to the other interdisciplinary cases, right? Where most of the time doctors, they didn't see the need for ortho, the value for ortho, and right now for us it's easier, and this is something I would like to share. Another thing that I would like to share with you before we start, and today we probably will surpass a little bit 1 hour, okay? I apologize for that because I have a lot of content. This is an important webinar. The experience, not only from my clinic, but in planning center here in DST Madrid, starting in 2021, just for you to have a reference, we did more than 1,500 DST Invisalign cases, where we could do here with our TPS, our treatment planning service, about 1,000 clean checks, the software from Invisalign, where we plan the cases, okay? So our team, working together with clinics, we did more than 1,000. And because here we have a protocol to always do a quality control to check if the position achieved in the clean check, in the end of ortho, was the same as the position we planned in the initial situation, we could validate a lot of our protocols. And this course is about sharing these protocols and sharing the most important concepts for you. I believe in the end, you can have a collection of tips and rules and protocols that you can use for your cases, independently of regardless of the system you're using, okay? Again, it doesn't need to be Invisalign, okay? We also created several solutions here that I'm going to just show very fast in the last webinar about the auxiliary therapies for SFLT with bone grafts and corticotomies, and also the use of skeletal anchorage. We create guides to use in very advanced guides. We are doing a lot of meetings, online meetings, to discuss cases with doctors. So this is an opportunity also for us to learn, right? And I'm very glad. And I can say that all cases were interdisciplinary, and practically all cases we recommended some adjunct therapy. Can be elastic, can be some device, vibration device, can be skeletal anchorage, because aligners alone sometimes they need some help, and this is what we face it here. So this slide is going to be a reference for our protocols, for you to remember that it's not something that just me alone I am checking and seeing my few patients in my clinic, but we are seeing this in clinics all over the world, and it's working there. So my expectation is that by sharing with you, you can put in practice and make it work for your patients too. Okay. As a summary, okay, as I mentioned, I would like this beginning here to share a little bit more about what we are going to discuss in the full course. Okay, today it's important because it will create a basis for everything we are going to talk in the other webinars. Okay, it's about diagnosing. So as I mentioned, I changed the way I am diagnosing my cases. Okay. Nowadays, I am doing a different process than I was when I start working as orthodontist. I'm going to share with you, and also I would like to discuss everything we need to check and the principles with aligners for us to achieve ideal smiles. Okay, so the most important thing, since we are talking to start from the final ideal, is to understand where is this final ideal, and this is diagnosis, right? And this is what about this first webinar. In the sequence, in this first part, the first 4 modules, they are going to be more theoretical. Okay, of course, I'm going to use clinical cases to exemplify, but I believe they are important webinars because I'm going to discuss our tools, the biomechanical tools we have, with a lot of tips about attachments, okay, how I use them, when I use them, how can we adjust them, about the staging or the sequence of movements that we need to create, about the use of these very common adjunct therapies, right, such elastics, ramps, and other additional tools, okay, in this third webinar. And to complete, to finalize, and to finish this part 1 of principles, we're going to discuss how can we improve predictability, and one of the most important concepts that I'm going to start talking today, which is overcorrection. When we are talking about orthodontics, we don't have, and I'm not talking about aligners now, I'm talking about any system. We don't have any system that can be 100% predictable. Okay, this is something that you need to put in your minds, in your heads, because sometimes I am reading articles and the authors, they are saying, okay, but this aligner is not working because we plan to achieve this position and we stay behind, 50% behind. But this is the same for braces, right? We need to bend more the wire. So this is something we're going to discuss to finish this first part. So today, digital orthodontics diagnosis, then in 2 weeks, aligners, biomechanics, attachments, and staging, and then more 2 weeks, elastics, ramps, additional tools, and then predictability on overcorrection. So by understanding everything, we'll be ready for us to start discussing our protocols. And here is something I discuss with the clinical and scientific director for OHIS, right? And he mentioned me the points that most of you suggested, and here we have what it was decided, right? To talk about protocols to solve crowning, protocols to solve class 2, class 3, open bite, deep bite, the cases where we need to do extractions and how can we improve predictability, right, to solve the case. A webinar for us to discuss growing patients, okay, more and more aligners are indicated for this profile of patients, okay, and we need to be ready. And also what I mentioned, the last one, more complex solution to achieve and expand the limits for our orthodontic treatment with aligners, with adjunct therapies. Please let me know if I'm going too fast, okay? And if you have any questions as I am speaking, you can write, and in the end, we are going to review all. So, starting here, today, the digital orthodontics diagnose rocks and principles for ideal smile designs. Okay, this is a topic that I like because it's part of my daily routine here where I'm working. We are doing this for hundreds of cases every month with an amazing team I have here. Okay, I wish I can have them all here with me for you to see, but it's not a one-man job. It's something that we are doing as a team. The same way probably you in your clinic, you have other doctors working with you. Okay, so the first question that I like to start is why we should move to aligners. Why not stay with conventional orthodontics? Why no keep using braces? Okay, in my opinion, in my experience, I stopped using braces for about more than 8 years, and I'm doing only with aligners. And in an interdisciplinary clinic, with this method for diagnosis, we can identify all the needs for the patient, and most of the cases need complex ortho. So we need to solve these cases with aligners, right? And even though in the beginning aligners they had a lot of limitations, and as any other system, we still have limitations. We need to figure out how to surpass them, how to overcome, and how to be better with this technique. Okay, and I believe this is something that you are all doing here, right? We are here for this reason, for together to grow, for together to understand how to be more efficient, more effective, to provide better care to our patients. But it's important to understand not only by the biomechanical reasons, but also the concept why we need to move. And to start talking about it, we need to understand what patients they need, right? And probably all of you, you have good explanations to explain to your patients why they need ortho, okay? For example, we can stay a whole day discussing this slide on the advantage of moving teeth, and this is not for aligners, this is for any kind of orthodontics, for to improve function, right? To provide, to preserve tooth structure, because when we move tooth, we need to prep less for a restoration, or we can avoid a restoration, right? We can simplify gum surgery for crown lengthening, or even when we need to do soft tissue graft when necessary with movements, okay? We can improve the gum, the pink aesthetics, right? By leveling the gingival margins, for example. We know that after finishing ortho, if we don't have the gingival margins well leveled, it's always going to be with this asymmetric feeling, okay? We can improve significantly the smile design and the facial harmony with orthodontics. We have in Brazil a famous plastic surgeon, the most famous in Brazil, and Brazil is the country for plastic surgery in the world, where we have the biggest numbers of procedures. And he mentioned in all his lectures that every patient should start their treatment with his smile, right? To improve the smile, and then think about doing any procedure in the face or in the body. So this is amazing, right? It's very important for us to use orthodontics. This is very important, orthodontics in this interdisciplinary field, okay? And of course, we can, by moving, distribute spaces, and for the cases we really need to do restorations, we can have a better crown morphology by placing teeth in a good axis, in a good position in the arch, okay? So again, I'm not going to explain more, because this is something that everyone at this point should know how to explain. But this is enough. This is enough for our patients explaining this, because sometimes the patients, they are ready to do the veneers, right? They are ready to do other treatments to avoid ortho, okay? So we know that orthodontics can transform a complex case in a simple case, okay? Sometimes avoiding surgery, sometimes avoiding restorations, sometimes closing spaces and avoiding implants, sometimes avoiding other procedures. So the whole idea with orthodontics is always to move in this direction, right? To move in the most simple case possible. And if we have healthy teeth, we can now actually avoid any kind of other procedure by doing orthodontics, and this is for the patient is amazing, right? So this is something that we know and we need to explain to patients. But what I am realizing, and this is a data that I like to share, this is based on our experience from our cases here, okay? And this is also a data that Invisalign collected, and also from the American Dental Association, that considering the interdisciplinary case, the cases that needs more than just ortho, the cases that the patients are not going directly to the orthodontics, the patients that are looking for improving their smiles, they're looking for the oral rehabilitator, okay? This kind of patient, we know that 74%, let's say 3/4, could benefit from orthodontics, have orthodontics as one of the specialties that are indicated for his case, right? And then starts the problem, because for us who have interest in orthodontics, it's a good number, right? It's 75% almost, so it's excellent. If of all patients this amount comes to our hands, it's amazing, right? But the problem is, most of them, they are not going to the orthodontist at first. They are looking for other doctors. And since this doctor, he's not prepared to diagnose orthodontics in most of the time, only 10 to 20% in a conventional workflow without the digital are really diagnosing the need for ortho. So we are losing a lot of patients from this box to the second one. And because of, for many reasons, those who are diagnosed, only 1% is actually being treated, okay? So this is an incredibly big reduction from this amount, from these patients that could do ortho to benefit themselves. And why? The explanation that I'm finding here from my side, evaluating and asking doctors and trying to understand everything, is because first, the patients, they don't want ortho, okay? They don't want ortho, and this is something we need to accept. We cannot understand sometimes because we can see clearly the value, the benefits. But if not even the dentists, sometimes who are not specialists in ortho, they can see the benefit for ortho, how can the patients could see, okay? So we have these two main factors. The dentist, the same way the orthodontist, and I'm also criticizing myself. I am as orthodontist, when I see an occlusion, I start thinking about tooth movement, right? The same way the surgeons start thinking about surgery, and the rehabilitators start thinking about restorations, and this is part of who we are, right? So here the patient doesn't want ortho, and adds the dentist who are not understanding the benefit, and he's looking for a way to finish, to do the veneers and to solve the case. So this is the most important reasons, right? And because they don't see the value, they think ortho takes too long, because if I can do it finish now this other way, why I'm going to spend 1 year, 2 years doing ortho? They don't think it's predictable in a conventional workflow, because they cannot see the final, they cannot see the ideal, right? In the past, we just share how we thought it would be. It's going to be like this other case, it's going to be good, it's going to be beautiful, but the patient couldn't see in his mouth, he couldn't visualize what we were thinking. So because of that, they don't know how it's going to be in the end, and they think it's going to take too long and it's not predictable. And everything added, it's going to be expensive, because if you don't understand, if you don't see the value, you're going to see as expensive, right? And this is the most important reasons. So we need to try to add to the explanations of what the patients need, to add what the patients want, right? And now they are clients, because they are only patients when they start the treatment. As clients, we need to know that they are going for this. They want a beautiful smile, point. They don't want plastic, they don't want braces, they don't want any other procedure. What they are buying is this beautiful smile in the end, okay? And they want to do it as fast as possible, the most predictable way as possible, inside their pockets, what they can buy, okay? And this is what they want, okay? So by my experience over years treating patients and hearing them, the biggest complaints about ortho, what they think about ortho, the first complaint is that takes too long, okay? So we need to try to find answers to solve this. They think it's not comfortable, okay? The comfort is a problem because it's something in their mouth, it's going to stay, it's going to interfere in the way here they are feeding themselves, the way they are talking. So this is something that is a problem for them. And they always think the ortho is taking too long, is not predictable. And because sometimes we fail to provide a good explanation and a good solution for this, they start losing trust in the ortho treatment. Okay, so this is something that we lose a lot of referrals to. Okay, so why aligners? Why we need to move to aligners? Because we are doing very well with braces, right? My first answer to this question is because with aligners we have better answers to these problems. Okay, and this is something I learned over the years, starting with braces and edgewise in 2001, and then starting moving to straight wire, static braces, and in 2001 my first experience with in-office aligners, and then only 8 years after with Invisalign. And a big gap here that I really try to do everything by myself. And as you can see, comparing a scale of results, time, and user experience, it takes a lot of time, but good results with braces, not a good experience. The time stays almost the same with straight wire. The result is the same. The time reduces a little bit. The experience grows a little bit because it's faster. With statics, although the time is the same as the edgewise, the experience is better because it's more static. Okay, and then with aligners, my surprise, because the treatment I was doing was very simple, very minor solutions, and even though I took too long to finish and the result was poor, the experience of patient, they thought it was amazing. It was great because I didn't need to use braces, and this is something that in this year some click happened in my brain, and okay, I need to study more about this. I need to start understanding how to provide better treatments, and this is what I did. And this is something that for all of you, it's a process. For anything we're doing that we are starting, sometimes, for example, when you certify for a new system for aligners, in the beginning you are going to see the lecture, okay, everything is easy, I'm looking to the software, I'm looking only to the successful cases, and I'm ready. So you start doing it, and then you realize, okay, it's not that simple. I need to do more cases, I need to treat different malocclusions. And when you start doing more than 100 cases, in my opinion, you can start understanding how it really works, okay? So here in my journey, after I started using Invisalign, it was a process that year after year, and adding more technologies, adding scanners, and in the DSD, I started to reduce treatment times, I started to improve results, and the experience for patients with any difference, every little technology that I added increased a little bit their experience. And this is something that I realized that is very important, and this is why I consider aligners. So for me, I start becoming a fan of aligners in 2008. Even though I was suffering to treat the way I like to treat my patients, so I convinced myself that was the way, and I started studying more and more and more to understand how to solve the cases. I need to do some cases and show to my peers, to my colleagues in my clinic, the results, so they convince themselves also. And the easiest one to convince was the patient, right? Because the patient was the one who really wanted a solution like this. Okay, our patients were ready for a solution like this, so they came to us asking for solutions like this. And actually, all major changes in our field, orthodontics, were guided by patients' needs. Okay, so the braces from banded to bonded, from metallic to ceramic, then from buccal side to lingual side, and then aligners, everything were guided by the patient's need, and we need to understand that. So with aligners, we also, although we can have good softwares to indirect bonding, but only with aligners we have a complete digital system, okay, for 3D digital orthodontics. So we can better diagnose. This is something that I believe you all agree with me. We can have better predictability, although we don't have 100% with aligners. It's actually very far from this. The studies are showing that we have in average 50%, and this is something we're going to discuss in other webinar, this course. But we can control this. We can find strategies to overcome, and we can understand better the number of aligners, the treatment time, so we can explain better to patients and they can trust more in this part, okay? The communication is much better because we can show to the patients the movements, we can show how it's going to be in the end, and what I'm going to show to you is the integration with the face and now other aspects today that can really increase and improve this item here. For sure it's a better experience. I am a patient for aligners, my wife is, I have a lot of friends I treated, and the feedback I received for everyone, I'm still married, so it was good for her. It's that aligners provide us a better experience, considering the comfort, considering that it's a removable, considering that it's easier for us to brush and floss, considering a lot of aspects for our life that it's improved by the use of aligners. And for me, one of the most important part is the facilitation to the communication in the interdisciplinary team, okay? It's not like my orthodontist, my oral rehabilitator asking me, Daniel, please open 0.5 millimeters distal to the laterals because I need the space there. And then I was there with the braces doing the treatment, and then I send back the patient, but it's not there yet, please move more. Now we can plan together, right? We can share our ideas before starting the treatment, and this is something that is amazing, okay? And here, as I mentioned, in the past years, we are not just doing light dentistry with light movements just to do the veneers. It's the opposite of that. We have been doing a lot of cases with skeletal anchorage, SFOT, accelerated orthodontics, surgical cases, with veneers, with prosthetics, with implants, all kinds of cases, and this is something that aligners can do, okay? And summarizing here, the biggest difference between aligners and braces is regarding the digital workflow, right? Because with braces, we can look to one screen and try to repeat in patient's mouth in a very slow process, okay, and very hard to monitor if we really are doing exactly what we plan on the screen. And with aligners, we can talk because we are using the software to create all the stages and to move in the software to the final position. So it's easier for us to transform these virtual simulations in real outcomes, okay, in a much more predictable and precise way. So for me, the biggest why for aligners is this, all these concepts that facilitates the communication among the team and also to provide to patients a better experience. Once we start treating patients with aligners and understand the concepts that I would like to share, I'm not saying that I'm the owner of the truth and the only truth is what you are going to hear here, because you can find a lot of other amazing courses, including inside OIS platform, okay, about aligners. So the idea is for you to collect all this amazing collective intelligence, and I'm here to share my experience, the way we have been doing here in our team, and we are having a good index for success, and I hope you can use some, at least, of the strategies we are suggesting, okay? So for us to start now talking a little bit more about orthodontics, I would like to review some concepts with you, okay? First, about tooth movement, okay, which is something that is going to open a little windows for you regarding what we are going to do later with the aligners, okay? So when we are talking about orthodontics, with aligners, we need to understand some concepts that are the same for braces, for any kind of orthodontic system, and other biomechanical principles that are more related to aligners, for us to also understand the limitations and how can we improve them, and the other points that can be better than braces. So it's important for you to understand, okay? So talking about tooth movement, and I'm not going to waste a lot of time here because I know this is the boring part when we're going to talk about histology, but it's going to be super fast, okay? We need to understand that we have two moments of the treatment that we need to consider. Both are very important because one, we are moving teeth to the ideal final position, and the other one, we need to stabilize there in a retention, Okay, so by understanding what is happening, we can provide better solutions for each phase. Okay, so the active treatment, the most important actor here is the osteoclast, right? Together with all other inflammatory cells, they are opening the path, creating the path for the tooth to move. Okay, so they are the bone eaters, right? So with orthodontic force, we can stimulate, we can promote this inflammatory response, and then the inflammatory cells, they're going to differentiate themselves in osteoclast, osteoblast, and they're going to work to create this bone remodeling process, allowing tooth to move. Okay, and then in the other side, although they participate during orthodontic treatment, okay, but they are more present in the retention phase. They are the most important actors in this second part of this movie. We don't have tooth movement anymore, but we also have bone remodeling with bone formation. Okay, so they are the bone builders, the osteoblasts. So they are increasing bone density and creating a new bone. Okay, to stabilize the final position. So understanding this, okay, we need to know that during these two processes, first we are decreasing bone density and activating the movement, the other one we are stabilizing. We have some theories, okay, that in the past they understood that this direct theory, that targets the bone where we can put force in the bone and then it will remodel, it's bullshit. I'm sorry to say this word here. It's going to be recorded, so if you can translate differently, please. We know that is not going to happen because with implants we cannot place force and create movements, okay? And also for ankylosed tooth, we won't have any movement if we don't have an important character here, the periodontal ligament, okay? So the second theory is the indirect, that by the compression of the ligaments, the periodontal ligament, and the tension, we are going to stimulate osteoblast and osteoclast, and this is going to happen very organized in one way, osteoclast, another way, osteoblast, okay? The most recent theory is the biphasic, right, where we can have all the cells together, okay, and everything is happening at the same time, and we have osteoclast everywhere and cytokines everywhere, and we are going to target the ligamental periodont, the periodontal ligament, okay, and what we are creating is an inflammation, okay, and this is something that what we want to stimulate in the limits where we can this inflammation, okay. We have a lot of articles showing that the use of anti-inflammatories, for example, can significantly reduce tooth movement. Okay, so this is something that's important for you to check with your patients. Sometimes it's not happening in the movements, it's losing track in the aligners, and we don't understand. And this is the kind of patient that play tennis every week, and then he always using anti-inflammatories for the pains. So it's something that we need to check. Okay, and also we know that by other studies that by creating this inflammation, we are going to allow tooth to move, okay? So the first brainstorming here, and this is important when we are going to do the plan and we're going to communicate with the company in order to create the ideal force system to move teeth, okay? Can we increase force? This is going to be effective in order to improve the rate of tooth movement. This is something that makes sense. Or it doesn't matter if you're going to input more or less force, okay? It's going to create a difference, but we have a limit, okay? And this is where I believe this is one of the biggest advantages of using a good system of aligners, because of their big data and number of cases done by orthodontists, they can calibrate better this force system, because we know by several articles, and this is one that if you want, you can use this QR code to check this article, that after certain magnitude of force, there is a saturation point, okay? So we cannot put more force than this limit, and because we are not going to move faster, we're going to actually decrease the rate of tooth movement, okay? Because the inflammation is going to be bigger, and then it's going to react as a problem, and that's not going to allow toothing until it rests and it reduces this inflammation. Okay, we know also that for teenagers and adolescents and younger patients, we have a bigger limit of saturation, so we can use more force, and this is why treatments for teenagers and young patients, we can change aligners faster, okay? But for adult patients, we know that without acting in this other side, the bone remodeling process, we need to respect the activation force of the aligners and not change aligners faster than it's possible, right? And how much is the protocol that is ideal? Let's discuss this in future webinars, but it will depend on each case, okay? And now, understanding that we need to calibrate the force, and the software is the best tool, much better than our hands, because with braces we are kind of artisans, right? We are doing sometimes less force to avoid surpassing this limit, and this is why sometimes the treatment lasts more, okay? With aligners, I am using the artificial intelligence of the software to help me calibrate that. It's much easier to calibrate because we know by a lot of amazing orthodontists, right, from the past, from Tweed to Roth to other important reference, that we have for each kind of movement a specific amount of force that it would be ideal, considering a normal patient, right, with good bone, with a healthy patient, right? So for intrusions, we don't need a lot of force. For translations, we need more because we have more bone over to overcome, right? So with the software, we can calibrate and individualize each of these movements. Of course, Invisalign already have, this is something that they are not going to share because is their Coca-Cola formula, right? But we have a lot of other software that we can manually do this and use our knowledge to personalize this, okay? But considering aligners, what can be done and what are the 5 main rules for aligners? First, we need to understand that differently than braces, where we can insert a wire inside a bracket and have 3D control with the metallic or the elastic holding this wire inside the bracket, we can move teeth, push, pull, and do everything with a good hand and a good wire and a good plier, right? With plastic and aligners, we can only push teeth, okay? We cannot pull. We cannot have an attachment that is retentive, at least until now, okay? So we need to create force systems that understand this. For example, if we want to rotate this one, we need to create points of pressure here and here, so we can, by pushing this area, move teeth. Otherwise, we are not going to do this. Other good example for this is for extrusions, right? If we take this cuspid if we need to extrude and it's expulsive, not retentive crown, we don't have where to retain the plastic, right? And then we're going to lose tracking, right? But by placing an attachment there and creating this area so the plastic can push, we can be more effective in this situation, okay? So we need to understand this, because if we want to move a lateral, extruded, these kind of movements, we need retention to the plastic to push, otherwise it's not going to happen, okay? So here you can see, with braces, we can do the force in the bracket and pull, right? With aligners, the force is going to be in the other side, in the lingual side here, to push. And by understanding this, we start having more clear ideas when seeing a plan, okay? This is a big advantage here, okay? I like to share for my orthognathic cases when we want to do segmented surgery, that we need to prep the quadrants or sometimes in 3 different parts the maxilla, and then the surgeon is going to put these parts together after. We can do a lot of different movements in each area at the same time. Okay, so I like a lot aligners because the tooth we don't want to move, or we cannot move, we can click the software and remove movements. If we need in the quadrant 1 to do expansion, we can do. The quadrant 2 can do intrusion. Of course, we need to think about anchorage, but we can do. So this is a case for orthodontic surgery, for example, that evaluating her design. So you can see here in white, in this photo in the middle, that this position of this design that we simulated in the computer was good, and overlapping with her actual position, it was leveled with her incisal edge. So for this case, we cannot solve by extruding, so we can keep this area here without any movement and concentrating intrusion in the posteriors. Okay, so the software that we can do pretty much is not going to move anteriors, and we can do different movements. So with aligners it's much easier to do this. With braces, sometimes by intruding the posteriors, we are going to extrude the anteriors, and then we need to compensate, and then it's going to need more time is going to be needed. Okay. Rule number 3, we need anchorage, and this is something that is the same for any kind of system. Okay, being braces, aligners, lingo orthodontics. If we want to intrude the anteriors, where we are going to support, we can use some bite ramps, but for aligners we need to block and retain the plastic in position so we can have enough force to do this. Okay, so overcorrection is needed. Okay, this is something that we are going to discuss a lot, because the studies are showing us that we need to overcorrect movements, because the plastic can provide a limit of movements if we put the teeth in the perfect position. For example, this case here is the perfect the ideal final position done by the technician in a line. Okay, and here is how much I overcorrect, almost leaving an open bite. I'm thinking to leave the patient with an open bite? Of course not. I'm thinking on having him in this position, but I need to overcorrect if I want to get there. Okay, and this is not new in orthodontics. Let's be fair. Okay, with braces we did the same thing in a very accentuated, a very big curve of SPE. If we want to do the planification of this arch, the shape of the wire should be like this, and here we are overcorrecting, so the wire is going to have enough force to move teeth to the position that we want. Okay, so one thing that in the next lectures I want to make it clear is that the CleanCheck is not a software to simulate final position. Okay, ideal final position, or any aligner software is not made to simulate the ideal occlusion, the ideal final position. They are softwares to create force systems. So when we are seeing the screen, the teeth, actually we are seeing plastic, we are seeing wires, right? And there is where we are going to create the strategy. And finally, the last rule, and this is something that again, it serves for all kinds of system, we need space to move. Okay, so by having a software that can help us in a much more accurate way to calculate how much space we need, okay, if we need to do IPRs, interproximal reductions, and when, this is amazing. Okay, because in the past, I need to confess, sometimes I just check during the appointment after removing the wire. Okay, with the flaws, here's the contact's too heavy, let's use a strip to reduce, and then we keep doing this during the treatment until we could achieve the final position. And sometimes we remove more from one teeth, and then we can change the shape of the tooth and hurt the aesthetics and remove enamel. So by having a software to help us, we can calculate how much space we need, and this is going to save a lot of tooth structure for the patients. Okay, I'm talking concepts that you should use to talk and explain to your patients the benefits of using these aligners, right? For them to know what they are investing, right? So this is very important. So here, if you want to take a print screen to remember, be my guest, no problem at all, but this is going to be recorded, you can see later, okay? Aligner biomechanics fundamentals, okay? We have two exclusive for aligners, that aligner only push teeth, and we can do multiple movements at the same time. And basic orthodontics. Anchorage is needed, overcorrection is needed, and space is needed, okay? So by having everything together, these concepts and how we can move, of course, this is only the basic part, and we are going to understand how can we create protocols inside the softwares, how can we communicate with the technicians, regardless of the system you are using, okay? I now would like to use this final part of this first webinar to explain in a very, expect to be a very simple way, in a manner in a way that you can use, even if you don't have the same software I have here, Nemotech, how to improve your digital diagnosing, to understand where you want to go before starting planning the movements inside the software. Okay, so here again, by doing digital diagnosing, using softwares, we can simulate different plans, we can use for the team brainstorm, we can start by the final ideal and do the reverse engineering process, and the most important, summarizing again, make mistakes in the computer to avoid errors in patient's mouth. Okay, so here it's something that I like to repeat to my patients and summarize the biggest advantage of using the digital for orthodontics. I'm going to exemplify the importance of simulating everything before starting any ortho plan with two cases. Okay, one, the digital saved my skin, does not say anything different. Okay, I was saved by the digital because here we have a friend of mine who looked for my attention, for me to evaluate him, looking for orthodontics, okay, to improve his smile. And when I start analyzing, something told me, okay, I need to simulate before ordering aligners, ordering any clean check, okay? And I send this case to the planning center so we can do a simulation, and we start developing a simulation for him. And this case that started as an ortho case by looking to the simulation to recover all the wear he has and placing teeth in the ideal position, I think you can agree with me that we don't need ortho to achieve that. All teeth are in a good position. We only need to do the restorations to recover, to build again what he lost with wear over the years, okay? So if I started for him doing ortho, I would over-treat him. I would generate costs for him and time, and in the end, it's not going to create any advantage for him. So by doing this digital diagnosis, by doing this digital treatment planning, simulating what is the ideal, we avoid doing ortho without any necessity, okay? But this is the kind of case that is rare. Normally we need ortho. Remember, of the 75% of the cases, right? So what I see more in my routine is exactly this kind of situation here. These other patients that look at us for doing veneers and doing restorations. And then we start doing the same process by, I'm going to explain a few the importance of each line, but just for me to exemplify, by doing this analysis, we can see that although minimum, we need to do some adjustments with movements, ideally to avoid preps and to avoid restorations where we don't need, if we want to create the ideal balance for her, okay? So by placing this reference for the gingival margin, incisal edges, papillas, midlines, we can easily see this. And this is something we don't need a software. We can do in your Keynote, in your computer, right? The same way DSD started, okay? You can use a planning center, of course, but I'm not suggesting this, only if you want. But here we can see that with intrusion, we can avoid restorations, we can avoid restoration of the premolar. And by showing this to the patient and overlapping here, look how much we will need to prep these anteriors if you want to achieve this ideal design, okay? And then patients start realizing, oh, now I can see, look the overlapping, look the differences. And here the most important part, by seeing not only the computer but also using this reference, this design, to do a mock-up in her mouth, she could easily understand what we were thinking, and she agreed doing this ortho. So this is a case that the patient wouldn't do ortho, and because we did this brainstorming in the digital platform before, she was convinced that it was the best way to go, because she created here a connection, right, during the mock-up and during the presentation of the plan. So the whole idea, and why digital important, because nowadays I'm using the reference of DSD Invisalign, but by doing these simulations, you can have the final STL files of the ideal design, and you can talk to your aligner company, you can see with them if they can use to as a reference. So there are many ways of achieving that, but in this complete digital workflow, we can test in the computer, test in patient's mouth, and then export to the CleanCheck, where we're going to use the same reference that now here you can see here in this light blue that is going to appear now. This light blue is the same design that we're seeing here, okay? And then we can guide the movements to this situation. So our amount of cases that could benefit from ortho, the day we started using this workflow in our clinic and well clinic in Brazil, not only these cases where it's very clear the need for ortho, a big crowding, that is the patient accepted ortho, understand, but mostly for these cases that sometimes most of the time patients, they don't see the value, we could diagnose 100%. And why? Because with these images, it's very clear for everyone, for the patient, for the dentist, and it's easy for the team to share with the orthodontist. So we can have everyone putting their insights in this case, and it's very unlikely to not diagnose the need for ortho, okay? And because we can, with the digital aligners and now the softwares, share with the patient with images and tests in their mouth, we have a high index of acceptance, okay? This is something, this is numbers from our clinic in Brazil. So this is something that is very good. So how is this process, and how can you adapt if you don't have DSD, if you don't have the Invisalign, if you don't have this collaboration? I'm going to share some step-by-step ideas that I believe is going to facilitate the way you see your cases, right? Because in the past, I received the documentation for the patient, okay? I received the photos, the models, not the STLs, because as I mentioned, I'm orthodontist for 20 years, and I start looking like in an intraoral evaluation. I learned from my formation that we need to achieve class 1. Okay, so a class 2 like this, I start thinking about, okay, I need to distalize here. I can use, I have a lot of applies. In the past, I can use extraoral, I can use TADs, I can use coils, I can, a lot of biomechanics that we can achieve a class 1 if we are just looking to achieve a good occlusion, a good intercuspidation. But this is the best for this patient. Can we know this by looking to this, just looking to the cephalometrics? No, or we cannot know, okay? But if we only do the documentation and send to a company, in my case for Invisalign, what we are going to receive is this. This patient has a huge deep bite, okay? And the CleanCheck here, the software, is suggesting to correct by intruding the anteriors, the upper anteriors, and also the lower anteriors, okay? And leaving her in this final occlusion here, okay? So this is something that I need to understand if it's good or not. We can correct the deep bite like this. Maybe leaving a class 2 is a good decision or not. Maybe we need orthodontic surgery, okay? But if we only approve the first plan that it came, this is the solution that it was proposed, okay? So we need to understand that we have several other aspects that we need to evaluate and check, not only the intraoral occlusion, okay? And this is a critique that I do to myself in the past, and when I see in orthodontic congress doctors showing, look how beautiful is this smile, and then we can see an intraoral photo in a patient in class 1. This is not a smile, this is the occlusion, right? So we need to put everything together. We need to understand that if this occlusion that is being proposed in the software is going to be in accordance with the face, if it's going to be facially driven, if the final occlusion has the articulations, the temporomandibular joints in a centric position, if we don't have any other asymmetry that we need to correct with surgery or to compensate, and if we are respecting the airway aspects, okay, if we are open in space. So for the previous case, if I retract the upper, I'm going to reduce space, and this is kind of a forbidden thing nowadays, considering that we have a lot of information of airway sleep apnea, right, and we need to take in consideration. So what I'm proposing here is to guide our diagnosis by first a facial analysis. Let's forget about the occlusion for one moment, okay? Let's put the models in the side, right? And just look to the patient's face to understand where we need to move. And let's create first the ideal position for the upper, okay? And when I'm talking to ideal position for the upper, I am considering vertical position of the anteriors, anterior posterior relationship with the face, and also the transversal, right? And I need to respect area and need to respect the face, and I need to respect the articulation. I need to respect a lot of aspects here if I want to succeed, okay? So how can we understand the upper first? First, we need to have some new pictures, okay? The original documentation for orthodontics, usually we have like a ID is a photo with the patient serious, with the lips closed, right? And then we have a smiling picture that we don't guide the patient to smile as much as we need. We need to ask them to provide a full smile, at least the biggest smile, the most natural smile possible. And here sometimes it's hard to do it in a photo. So we recommend also doing videos, okay, within a good head position, doing videos very straight to the patient talking, trying to make them smile, okay, so we can capture the smile. And the conventional orthodontics, besides this rest position with the lips closed and the smiling picture like this kind of not natural smile, also a profile picture that we have in a rest position. This is the basic orthodontic photograph, extraoral photographs, right? And then we have the intraorals that we can easily substitute with one scanning nowadays. What I am proposing here, first, we need to understand where is the vertical position of the centers. To understand if the plan that I share with you in the clean check is correct to intrude, right, the upper anteriors or not, or maybe they are good and the problem is the lower arch. Okay, so here with this, the most natural smile, we can understand if we have margin to intrude the upper, and here we can see that the patient is not showing her gingival margin, so we don't have much margin because we don't want to make her smile older, right? And also in rest position, we should ask patient to open the lips, right? To relax, to close, and then like they start breathing or start talking something, to open, because they smile, and the final position needs to be beautiful, not only in the one static photo, but in rest when the patient is talking. And we cannot expose too much, and we cannot intrude and reduce this exposure that she already has that is good here of her centers. So by looking only to these two pictures, I can understand that her centers are in a good vertical position. And then with this information in mind, inside your software, you need to take this in consideration and not intrude or extrude these centers and use them as a reference to all the others in the vertical, okay? Then here it's easier, of course, if you have a planning center, if you have a DST Invisalign case, if you are using an Nemotech software or any other software that you can simulate, because we are simulating here a good proportion for the centros, and then we keep in the same level her original centros, and then we remove all the interference, simulating the final simulation, then we place in her smile, so we can actually see and test in the computer what I mentioned, okay? So here we convinced ourselves, okay, the vertical of the center is good. Let's move on, okay? Now we need to understand the anterior posterior. it's very important for a class 2 case. Can we distalize the upper arch? Can we retract? So here, look to her profile. We have already a concavity, right? And we have the incisor retroinclined in a class 2 too. So we need to procline a little bit the incisors actually. And this angle here of the nose, if we retract, we're going to make it worse, her profile, okay? And we have this other, and this is important to have the profile picture smiling, right? This is why it's so important. We need to evaluate the smile, and for me, it doesn't make sense to only take a photo with the patient in profile in a rest position with the lips closed, okay? So we need to see this to have all the perspectives of her smile. And this other angle we call the 12 hours picture. It's a very good picture. I put a zoom here. Normally we took from a bigger difference, we can see the eyes of the patient. So it's good for us to understand the relationship of the upper incisors with the lower lip, okay? And also any midline asymmetry. It's a good angle for us to evaluate that. So here we can see that the anteriors are in a good relation. This lateral a little bit too procline, but the centrals, they're in a good relation. So we don't have margin to retract, okay? Maybe the lateral a little bit, but all the others, they are good and actually need to procline. So how can we correct this class 2? By retracting the upper, okay? We cannot. We need to keep the upper arch in a good position that it is already, okay? And then try to figure out by moving, or how can we adjust this class 2 by changing the lower that is actually is the one who is wrong, right? So the anterior posteriors, again, by simulating here, we can see her smile, and it's easier for us to identify by placing the design in the ideal position. We pretty much are retracting a bit the lateral, proclining, correcting, decompensating is retroinclined incisors, okay, and keeping the same level of the vertical. So here is the ideal anterior posterior to her face, and we are respecting the array because we are not going to correct the class 2 by retracting the upper arch, okay? Next, transversal, and here also important for the array, important for aesthetics. Since we already have the anterior posterior, since we already have the vertical, now we need to understand if we need to expand or not, and normally we need, okay? We always want to open space, and here is very clear that she has wide buccal corridors, dark shadows here, and it's going to do good for her smile to expand. And again, here we go, simulating and seeing the effect on his smile. The aesthetic is very clear, but also it's important here. I would like you to, if you don't know, to take notes. This is based on several articles studying sleep apnea, airway issues, that one of the risk factors that it's going to start a alarm here to, okay, this patient may have some issues as when we have interpremolar distance reduced less than 27 millimeters, and intermolar distance, the first molar and the first premolar, less than 34, okay? We need to measure this ideally in a CBCT, because what we want to see is the bone there. So since for some cases you won't have a CBCT, I suggest you to move a little bit more inside, more to the midline here, more or less 1/2 millimeter more to the midline compared to the gingival margin of the premolar. So for her, we have 23.2, and then in the molars 27. So we have two signs here, two risk factors, and adding the fact that she has a retrognatism in the mandible, we have several risk factors for sleep apnea that we can improve with orthodontics and make her breathe better, right? And may reduce the risk for her to develop sleep apnea in the future. So this is huge, right? I am 10 minutes over my time, but I just want to finish, okay? I hope you are enjoying and you don't mind, okay? So here we simulated an expansion to be the most we can close to these numbers here, okay? We are almost 27, almost 34, adding that the fact she doesn't have any issue by now, we finishing this expansion, but always improving and not reducing, okay? And then after understanding here, we understood and positioned the design in the vertical, anterior posterior, and transversal. So we know exactly where we need to place the upper. So now it's easy for us to understand what we need to do in terms of treatment planning, okay? Because now is the moment to create a function to understand the TMJs and the occlusion, okay? So at this point, it's good to place the mandible in a centric position and to see where is the most comfortable position for the patient, okay? So by understanding the upper ideal, we will define the lower treatment, okay? So for her, we can simulate a lot in the computer, okay? So we have some options to correct a class 2 when we cannot move the upper, okay? Unfortunately for her, we cannot move to correct to a class 1 only with ortho. This is only with orthognathic, okay? Here is where we found the best occlusion possible, keeping her in a class 2. But even though we are not correct class 1, look how much we need to procline. And do we have bone here to do this? So we have some decisions, okay? Only with ortho, we are going to have a very retrographic mandible, a big overjet, and not the ideal occlusion. To achieve class 1 orthognathic surgery that I can anticipate for this case, the patient didn't accept that at first. And what we have in between, this is something I'm going to explain in the last webinar. For this patient, in a spoiler, we did a procedure we call SFOT, surgically facilitated orthodontic treatment, where my surgeon in Brazil, he did bone graft and corticotomies to create bone where we're going to move teeth. Of course, we cannot put bone as much as we would need to correct class 1, but at least to achieve this final position, we study and we did a simulations, it's possible, okay? And this is a bonus feature for her. Look how much we need to intrude. And then the corticotomies here and the bone graft makes a lot of sense because we have 7 millimeters to correct in terms of deep bite, okay? So of course, this is a very complex case and you're going to see the evolution of this case during this course, okay? Because it's an ongoing case. And of course, we can, since 7 minutes a lot, we can use opening the vertical with tabletops in the posteriors, extrusion, so we have several ways to adjust that. And of course, we need to evaluate a CBCT for a case like this to complement the diagnosis to how to treat. So we didn't decide to do this procedure of bone graft only imagining, right? We first defined the upper and then we understood that here we don't have enough bone to do all this proclination, and here we need to add because the roots already are moving out of the bone. So we need to place bone there to where we're going to move teeth, okay? And here is the simulation. What we understood as a team, that would be a balanced occlusion, although she's in a class 2, but we could distribute the occlusion context, okay, and not moving the upper, keeping the upper in position, of course expanding, aligning, leveling, but not in the anterior posterior we are not retracting, in the vertical we are not intruding the same way the original plan was, okay? And here is the difference, right? Look, the overlapping between initial and final of the first plan done by the company, done by Invisalign, done by a technician without any reference. And here when we start planning with the DSD and now this facial and array analysis to understand that the upper we cannot intrude because we just intrude the minimal just to the later with some composites to adjust these incisal edges, okay? And we are going to correct this deep bite with adding bone, corticotomies, extruding posteriors, maybe adding some tabletops. And again, look how much we will need to intrude the lower, and here with overcorrection, again as a spoiler, okay? So, to finalize today, and open space for some questions if we have them, okay? This is in summary how we are diagnosing, creating our treatment plans, okay? We deeply analyze the photos, then we start understanding where is the upper ideal, okay? This is the moment where it's a good moment for us to do the motivational appointment with the patient, okay? We can first test to see if the patient is going to like, and then we, in the plan, we are going to adjust the lower according to the upper ideal. And here we have some options. Sometimes patient won't accept any of our strategies. Imagine if she doesn't accept orthognathics, she doesn't accept the SFOT, and she just want to do with ortho. I probably what I would say to her is, okay, I'm not going to do it because I cannot intrude these anteriors in the lower arch without any help, okay? But a lot of doctors, without any study, could start doing Invisalign as the plan Align provided to me without looking deeper, right? And then we have what I call the golden road, right? The ideal treatment plan to convince her to do the ideal. Unfortunately for her, the ideal is orthodontic and she wants to avoid it. She's a adult patient, she doesn't want. And when we try to adapt and we can do everything of this before starting, this plan with the SFOT, which she accepted, we found a good occlusion, okay, not a perfect class 1, but let's be fair. Today, I believe class 2 is the new class 1 because we have more people around the world with class 2 than class 1, right? And we need to find ways to achieve a good occlusion, leaving the patient in class 2 sometimes. So, any questions? Please, the team, Valeria, please help me if we have any questions, if you want me to come back. But the whole idea today was to make this review, okay? Because you are going to see me in the other webinars discussing how to solve class 2, how to solve deep bites, how to solve class 3s. And this is going to be the basis for my diagnosing process. And by understanding this in this first webinar, I believe it's going to be easier for you to understand the next ones, okay? Let's see, no questions for now, but I'm going to be waiting here if you want. Just for you to know, we have like a chat inside the platform, okay? And if you realize you have a question later, if you want to see again this webinar and then you realize, oh, I didn't understand this, you can write there, correct, Valeria? And we can answer later too, okay? Because this is a course that you can enjoy not only in the live webinar, but also later, and you can take advantage of being part of this course and try to collect the most information you can, okay? Let's wait for more for if you have any questions. But again, if we don't, and if you are going to see this webinar recorded later, please send the questions and we'll be very glad to answer. Okay, let's see. Still no questions. So I'm going to be waiting until the team inform me that it's good for today, and let me know if you have any questions. But if not, Valeria and the team, please let me know when to finish. Okay, this is a good question, okay? How can we transfer head position and occlusion count to Invisalign? I'm going to answer by showing, let me leave here the presentation, and I'm going to move to this software that we use, okay? The best way to do this is by overlapping STL models with the face, okay? We have several softwares that can do this, but here we can do in the software we use, Nemotech, it's software that is available for anyone to buy. We can do this overlapping, okay? So we select the most natural position of the head, and then we select a lot of points here to overlap and to fit the STL model to the face. Because in Invisalign, if you're going to look to the clean check, it's going to come like this, right? So it's leveled by the floor, and this is not good. We need to understand. If you don't have this software, my suggestion is to, inside the clean check, you need to have a picture of the face, and you need to always move until you find the best, the closest position according to her face possible. Okay, but here, since we have the software here, we can do this by just overlapping the model STL file with the face. Okay, and then we start placing all the frame. Okay, so when I understand the vertical, I'm going to place this vertical green line, the horizontal green line, to give me the vertical reference for the incisal edge of the incisors. And then I'm going to calculate here more or less the good proportion of a central to place the other green, the blue line to the gingival margin. So normally we try to reach the 80%. Okay, then the midline of the face, and then we start to understand this line needs to be imbalanced with the lower lip, and then we use it to place the design, so we can see in her face. So the same way you can overlap, we can actually see and simulate. So sometimes we place the midline and then we move to the face is not good. Okay, so how can we transfer this to Invisalign? With the DST Invisalign collaboration, okay, and this is the only way we can do this transfer in an official way and have it inside a clean check. When doctor order a DST Invisalign case with us and he approves this design, we are going to export this final position and this STL file of the final position design inside a clean check. So even if it's not aligned with the natural head position inside the clean check, you know that the final position is there using the blue transparency that I shown. Okay, and you're going to guide the clean check by this that you already checked here. Okay. Do you perform, the second question, do you perform cephalometric analysis? What method you use? Yes, for sure. Okay. Here at the planning center, I always encourage doctors to send us the full documentation, and we can use digitally here inside the software. Okay. So Nemotech is a good software because they have all the analysis, and we can use the 2D cephalometrics, and also we can use the 3D cephalometrics. Ideally, for cases, complex cases where we have asymmetries, the 3D cephalometrics, the craniometry actually, it's the ideal way to go, because we can measure the distance of the joints to the base of the cranium. We can measure asymmetries in the lower jaw. We can understand where is the most centralized and centric position for the lower jaw, and we can anticipate a lot of things, right? But for normal cases, it's an amazing reference for us to validate some of our decisions. In fact, we start with these lines, the frame, to guide the upper, okay? And then using a CBCT, we can check if we have the roots inside the bone. Okay, so it's a different method, because I'm not seeing angles, I'm individualizing every tooth. You can see here inside this software we can have a lot of data here. So let me show you the plan we did for the SFOT for her, where we added bone graft, so we can understand better how we can evaluate if we can, for example, increase the torque or not. Because I'm not concerned here about the angle. I can use the 2D cephalometric, having this regular X-ray, okay? But in my opinion, I have much more information by just seeing this overlapping here, okay? So here I can see where tooth is, right? And I can move the design, and if I need to complement, we can segment these roots in the final position according to design and see if we are going to have bone there after ortho. Okay, so this image here provides a lot of good information, because sometimes in the cephalometry we won't see if by moving this angle in the incisors, for example, the normal angle for 22 degrees, and here probably is a negative angle, we are going to procline if 22 is the ideal, right? It's just a reference. So for us, I like to use the cephalometry to complement. I usually use the regular measurements and angles, right? A and B, SNA, SNB, the convexity angle. Well, we can stay talking about cephalometry a lot of times here, but what is going to define is the design first, and then using the design to identify the final position of the roots inside the bone, okay? And by doing this, we are going to check if we need to add any adjunct therapy to achieve this position, okay? This is how we are doing. It's not the how I did in the past, okay? But it's kind of more 3D nowadays. I don't know if I answer your questions actually, because kind of mix a lot of information together. Any other question, Valeria? While Valeria doesn't answer to me about the questions, a lot of companies, they are developing their softwares, including the CBCT inside, right? So we, Invisalign can do this. With TSD they can, because we are going to do this before Invisalign, but other companies, they are showing the roots inside the software. So this is amazing. This is where everything is going, for this full integration of all aspects of the diagnosing process, right? So as soon as we have in the same software that we are moving teeth and creating aligners, the roots, the bone, it's going, I believe the regular cephalometry is going to be expired, right? And then we are going to be much more concerned about craniometry when we have asymmetries, to understand where we need to move or if we need surgery. And also we can use it not for all cases, but the CBCT is going to be kind of mandatory. Valeria, I think if you don't mind, and since we don't have more questions, I would say again, thank you so much for everyone, okay? I see you in 2 weeks, I hope, for us to keep discussing with more tips and tricks and solutions that I expect to be useful for your routine with aligners, okay? So thank you so much. I hope to see you soon, and let's stay in touch, okay? Bye-bye.